What do you know by restrictive lung disease? What is restrictive lung disease? See, there are two types of a lung disease. One is obstructive. We know the airway. Airway will start from the nose, then larynx, pharynx, trachea. Trachea will be bifurcated into two: primary bronchus, secondary bronchus, tertiary bronchus, lobar bronchus, and respiratory bronchial, and ultimately terminal, and it will be end into the alveoli. Yes, no. So ultimately there will be 12 generation will be there. So some diseases are upper respiratory tract disease, some will be lower respiratory tract diseases. We can classify into two. Again, we can classify it into obstructive disease and restrictive disease. And some disease will be mixed of both the variety. Yes. So sometimes you will get the only obstructive, sometimes you will get only restrictive, sometimes it will be mixed variety. And usually you will see the mixed variety more than these two. But we should know what is restrictive. Yeah. See, what is obstructive? In the trachea, bronchus, primary bronchus, secondary bronchus, tertiary, and terminal and respiratory bronchial, upper and lower respiratory pathway tract. Among them, there will be a thickening of the wall. See, normally our diameter, as you go from higher to lower respiratory tract, gradually it will be narrowed. So if you compare to the trachea and you can compare to the respiratory bronchial, it will be very less in the diameter. As you go from proximal to distal, central to peripheral, your respiratory tract will be gradually, the diameter will reduce from trachea to the alveoli. Yes, isn't it? Now you see, what will happen? Two type of pathology will be there. One thing is obstructive. So what is obstructive? Usually you met with so many different allergens or bacteria or viruses. What will happen? They will cause inflammation, and against the inflammation, our body cells, our lymphocyte, our monocyte, our WBC, like neutrophils, they all will be activated. They will fight with them. So there will be a inflammation till certain time when the inflammation, the bacteria is resolved. So till the bacteria or virus or pathogens are there, allergens are there, so we will fight with them with our WBCs. So ultimately WBC will fight to destroy them, destroy the foreign bodies, or we can call as a allergen. Okay, or we can call. So we can destroy them with our WBC. But now what will happen? Because of this process known as inflammation, our wall will be thickened. Our our epithelial cell will be thickened. So gradually, repetitively, recurrently, over the period of time, over the years, recurrent inflammation will come and go. Remission, relapse, remission, relapse. It will aggravate the condition, then there will be a sluggish. Then again there will be relapse and remission, relapse and remission. So continuously what will happen? Because of repetitive inflammation, our pathway will narrow. Our pathway will be narrowed over the period of time. This will happen in the COPD, in the chronic bronchitis, that may affect usually lower middle pathway tract, respiratory tract. And because of some inflammation, there will be some secretion, goblet cell hypertrophy, and ultimately this will obstruct the airflow out. The air which is going out of the lung, which is obstructed, the air which is going outside the lung which is obstructed, and ultimately there will be a trapping of the air inside the lung. So ultimately you will be having increase in residual volume and FRC. Ultimately total lung capacity will be improved. It doesn't mean your pulmonary function is improved, your vital capacity is improved. No, your vital capacity will go down, residual volume will increase, uh, you'll be having air trapping, hyperinflation, but ultimately you will unable to take deep breath in. That there will be a difficulty in breathing, deep breathing. So this is whole pathology will be there in the case of a chronic bronchitis, or we can call it as a COPD. There will be little change in the pathophysiology of bronchiectasis, chronic bronchitis, emphysema, cystic fibrosis, and all. Some diseases are mixed varieties, some diseases are alone obstructive. Yes, where there will be inflammation and hyperinflation lead to air trapping, and ultimately you will be unable to expand the chest and unable to exhale the air fully. We cannot empty our lung fully. This is the pathology, the main thing. Yes. Okay, now the other scenario, this is known as a restrictive lung disease. Again, it starts from the same allergen pathology. Once there will be allergen, they will meet, then continuously, repeatedly, you are meeting with the different varieties of microorganism, or we can call as a foreign body in the form of asbestos, silica, and so many different pathogens. What will happen? The person who are working in the factories, working in the coal miners, silica factories, asbestos workers, or farmers, those who met with a continuous exposure of the dust, like flour mill workers, or other pathology like this COVID-19 coronavirus, or the person with the pneumonia, or like bronchiectasis. So ultimately, any pathology, they will come and reside inside. They will be settled down inside the lower zone of the lungs, and ultimately your expansion capacity of the lung will be destroyed. When you're taking breath in, the lung should expand. Lung is having a compliance. Compliance is what? Ability of the lung to expand. Now, because of the continuous inflammation, wear and tear, your elastic tissue will be loosened. Yes, it will be calcified, or it will be mixed with the silica, coal, dust, and all. Ultimately, what will happen? You will be you are losing the compliance of your lung. The lung is unable to expand. Are you getting my point? What is compliance? Delta V by delta P. It means what? With the pressure changes, the volume also should increase. Volume should increase. But when you're inhaling, the lung will not inflate much. This is the loss of elasticity. Where there is an obstructive disease, it is already expanded. In the obstructive disease, it is already expanded. Whereas in the case of a restrictive disease, the compliance is decreased. Where in the COPD or obstructive disease, compliance increased. So here, in the obstructive disease, the lung is unable to empty, unable to come with the normal shape. It is already expanded because of more and more air content, air trapping. And here in the restrictive, what will happen? There will be already constricted. The lung want to stretch, lung want to go for expansion, but lungs property to expansion is lost. So the disease included in that all known as a restrictive diseases. So again, there will be two type of restrictive diseases: the restrictive disease of a chest wall and restrictive disease of a lungs. Both are different things. Example, I will tell you, the kyphoscoliosis. Kyphoscoliosis is an example of the chest wall decrease in the compliance. Then ankylosing spondylitis, where you cannot inhale deeply. Yes, because the chest is rigid. Yes. Third thing I'll tell you, weakness of your diaphragm in case of a respiratory muscle paralysis, quadriplegia, DMD, Duchenne muscular dystrophy, where there will be a gradually respiratory failure will happen because of the weakness of the respiratory muscles. In all the cases where you be having a inability to expand your chest, this is known as a restrictive. Now we'll talk about lung compliance reduction. So what are the disease can lead to decrease in the expansion capacity of your lung? The first of all, you'll be having a pneumonia. Most common, whether it is COVID pneumonia or whether it is bacterial pneumonia. Ultimately, pneumonia can be included in restrictive diseases. Again, asbestosis, ultimately silicosis, asbestosis, hay fever. What will happen? Farmer's lung. They all are occupational lung disease, where there will be a collection of the very fine micro dust. They will lodge inside the lungs. There will be chronic inflammation and they will cause fibrosis. See, again, bronchiectasis, then pneumonia, then we can call as a interstitial lung diseases. So many different varieties. So they all known as a restrictive diseases. Are you getting my point? I look clear, Chay? So one is obstructive. Then in case of obstructive, there will be upper airway obstruction, lower airway obstruction. Asthma is included in the upper airway obstruction. COPD and emphysema will be known as a lower, moderate to lower respiratory tract infection. Then restrictive lung disease. Again, restrictive lung disease is related to chest wall and related to lung tissue. Yes, fine. Okay, so this is all about just classification or variation of the restrictive lung diseases. Now I'll show you the common term they will use in restrictive lung diseases. They're known as a diffuse parenchymal lung diseases or cryptorchigenic fibrosis alveolitis or interstitial lung disease. All are synonyms. Restrictive terminology is broad terminology. Restrictive lung disease include all these things: occupational lung disease, farmer's lung, sometime idiopathic pulmonary fibrosis, IPF, we can known as a. So all known as a restrictive lung disease. Yes. Interstitial means what? We will come across many terms. Interstitial lung disease. What is interstitium? So what is interstitium? Interstitium means this is the alveoli and these are the capillary network. The junction between alveoli and capillary network known as what? Yes, interstitium. So when there will be a fibrosis, when there will be a calcification, all known as a restrictive diseases. They involve air spaces, peripheral airways, and your vessels, and sometimes your alveoli. Yes, and these are the progressive. These are the progressive, which is irreversible. See, we cannot say that okay, pulmonary fibrosis, we can recover the patient from them. No, we cannot recover the patient from pulmonary fibrosis. Once it is established, we can just be there. We can just stay there. We can limit there, but we cannot reverse it. Yes. So where all so many different air spaces will be having inflammatory fibrotic changes, and then including the alveolar wall also. Yes. So many different terminology they will include. First of all is idiopathic pulmonary fibrosis. In most cases, in all the restrictive lung diseases, this will be most commonly having a disease where you don't know the cause of pulmonary fibrosis. Yeah, in the interstitial lung disease, this is the commonest one, especially happens in older adults more than 40 or 50 years of age. See, the age is 50 to 60 years. And after the diagnosis of IPF, ultimately there will be a very poor prognosis and survival rate will be 3 to 5 years. When it has been diagnosed with the IPF, ultimately within 3 to 5 years patient will be having this mortality, patient will be dying. Yeah. Then sarcoidosis. Sarcoidosis is what? It is multi-system. It is again a restrictive disease affecting the lower respiratory tract, doing the fibrosis only, but it is multi-system including multi-system granulomatous disease, which often involves the lung. Yes, it occurs in the younger age. Now you have to differentiate this. IPF will happen in the older age. Sarcoidosis will happen in the younger age, especially 20 to 50 years. But it will be having a good prognosis. We can survive the patient. Yes. Another one will be connective tissue disorders. 15% of the disease in all the ILD, this will be the cause. And this prognosis will be again whatever the histopathologic or radiologic findings will be that. According to that, we can do the treatment. Again, see, rheumatoid arthritis is again connective tissue disorders only. Yes, Raynaud disease, again it is a connective tissue disorders. So again it may cause fibrosis. Yeah. Pneumoconiosis, again it is related to occupation. Those person uh, who are most exposed to inorganic dust like asbestos, coal, silica, and they will be significant cause of ILD. Ultimately, they will cause a interstitial lung disease, but gradually it is decreasing because they are using protective gears. So nowadays it is decreasing. Then you'll be having a hypersensitivity pneumonitis. It is secondary to inhaled organics like dust allergens. Example, bird denders, domestic fungal spore. Huh? See, usually the fungal infection will be very rare in our lungs until and unless we'll be having a decreased immunity. See, in the HIV and in the corona patient, those will be having a decreased immunity, then this opportunistic fungal infection will be very common, like mucormycosis. But it is spreading in the oral cavity, they will affect the eye and nasal mucosa and all. But this hypersensitivity pneumonitis will happen in the deeply situated alveoli and respiratory bronchioles. Yes. And then lastly, IIP, interstitial, idiopathic interstitial pneumonia. They are not the IPF part, but a very small portion of the cases, this we can suspect the interstitial pneumonia also, which is idiopathic in nature. Again, last, drug induced. Sometime what will happen, will the surgeon or the physician may give some drugs, and the reaction to these drugs, they will cause fibrosis, and this is known as a drug induced ILD. So these are the vague areas or definition of this uh, restrictive lung disease or idiopathic interstitial lung diseases. Huh? But it is less frequent than the COPD and asthma. COPD and asthma are very much common, but in comparison to this, and the whole respiratory disease, only this account for only 15%. Yeah, but it affects pulmonary interstitium, connective tissue, alveoli, and some capillary endothelial cell. Also, it may damage connective tissue. Also, they affect the collagen vascular also. Huh? with the varying frequency, varying intensity. So the prevalence is not that much high as compared to the COPD. Yeah, but IPF is very much dangerous than any other things. Okay, so now how we can classify? So according to the ATS, American Thoracic Society, what is ERS? European Respiratory Society, and Japanese Respiratory Society, and Latin ATS. So many different associations have drawn our attention towards how to diagnose the IPF. Once the IPF is confirmed, the death is within 3 to 5 years. This is fixed. So early diagnosis is very important. Yeah. So exclusion of the other non-causes of the ILD, that is domestic or occupation, environmental exposure, connective tissue, drug toxicity. Other than this, all known as IPF. What is IPF? First thing is there should not be any domestic or occupational lung disease or any connective tissue disorders like rheumatic disease, rheumatic fever, vasospasm like Raynaud's disease, so many different things. There will not be any cause behind the lung fibrosis. The first thing is this. Then the presence of unusual interstitial pneumonia. Routinely, if you go for the CT scan, you will see the clear-cut calcification and fibrosis in the CT scan. Yeah, and patients not subjected to, they go for biopsy. Again, they will go for they will feel the pneumonia only. If you go for the surgical lung biopsy and HRCT, the specific pattern has been found. And then we can come to know that, okay, the patient is having a IPF. Yes. So how we can classify? Again, same as your rheumatic fever, major and minor criteria are present. Yes. So what are the major and minor criteria? First thing is exclusion of the non-cause of ILD. Interstitial lung disease na બીજા જે cause છે એને આપણે rule out કરવાના છે, like drug toxicity, environmental exposure, connective tissue disease. If it is not there, then if we can see the bibasilar reticular abnormality in both the lower lobes, you can feel the reticular abnormality. It means haziness. Or we can come to know that, okay, these are the very much opacity you are feeling, like in the corona, reticular opacity, or we can call it the minimal ground glass opacity in the HRCT scan. And then if you go for the lung biopsy, transbronchial biopsy or bronchoalveolar lavage, showing no features of the any other diagnosis. So when you're going for different diagnoses and you are not getting anything, then you may suspect, okay, the patient will be having IPF. Fibrosis is confirmed. Then in case of a restrictive disease, you will be having a pulmonary function where the vital capacity will be decreased. But in comparison to the vital capacity, FEV1 is also, in comparison to FEV1 is not decreased. The force which can exhale, that is remain same. So ultimately, if you go for FEV1 by FEC ratio, the ratio will be increased, and that is confirmed that patient is having a restrictive disease only. So with that, the patient will be having an impaired gaseous exchange. The alveolar capillary diffusion will be decreased in case of IPF. Yes, and ultimately you will be having a TLCO or DLCO, diffusion capacity of the carbon monoxide. The diffusion capacity using this carbon monoxide test will be decreased. So ultimately there will be some problem in the alveolar capillary network, interstitium, because of fibrosis. Yes. And these are the major criteria, 4 major criteria and 4 minor criteria. Of course, minor criteria contains age need to be more than 50. Age need to be more than 50. If you see bilateral, if you auscultate the patient, bilateral lower lobe, you will feel inspiratory crackles, or Velcro type. How will remove the Velcro? So how you will feel the same like Velcro or dry quality inspiratory crackles. Inspiratory crackles means when you inhale, there will be opening of the alveoli, opening of the terminal bronchioles, and that is confirmed that the patient is having a restrictive diseases. Yes, the patient will be having a gradual uh, unexplained dyspnea. Suddenly patient is having, okay, I'm having the dyspnea which is gradually increasing over the period of time. Last month the dyspnea was not that much troubling, but now it is much more troubling. And you see, duration of illness is more than 3 months. The illness will be more than 3 months. This is confirmed that patient is having a IPF. Is this fine, student? Yes? Fine.
Yes.
Okay.
Okay.
Now, if we see, if we compare the IPF and this occupational lung disease, both are different. IPF is what? Idiopathic pulmonary fibrosis, where there will not be any cause. Automatic, okay, age-related fibrosis is happening. This is IPF. But now here we will get the clear-cut diagnosis, where it is job-related or association with some like asbestosis, silicosis, farmer's lung, or we can call as a this floor mill workers. Floor mill workers will be having a much more exposure of the dust, and because of this, it will be having a this pneumonia-like symptom. Yeah. So many job-related exposure or household, or so many people will have a habit of having pets. So because of birds or because of dogs, cat, because of them, there will be some particular type of dust or antigens will enter inside. They will come in contact with our lungs. So they will cause an inflammation, some water damage, or some mold or fungi will come and expose with this thing, mycobacterium. So many different ways they will known as environmental or occupational history, where we'll be having some cause. Okay, we can identify, okay, I went to the swimming pool, and then just after the next day or 2 days after, uh, i I come up with the many more symptoms. So it is related to this. So you can get the cause. Yeah. So you see, these are the interstitium, capillary, ND, alveoli, alveolar capillary network, where there will be an infection, or which is related to surfactant disorders or stem cell dysfunction or some allergic eosinophilic lung disease. Many more there will be a cause. It is not known as a IPF. It is included in the interstitial lung diseases. This whole thing can be diagnosed with the CT scan, HRCT, or bronchoalveolar lavage. What we will insert some clear saline water, saline fluid inside the lung, and we will aspirate, we will suction it out with the postural drainage and with the suction, coughing and all. So when we go for that, we will get we will test this bronchoalveolar lavage fluid. So we'll come to know, okay, these are the bacteria are responsible, or these are the pathology which is going inside. Fine. So what will happen once there will be an injury? Injury may cause again inflammation. Inflammation will not subside straight away. So once there need to be repair, proper repair and regeneration need to be there. Otherwise, there will be an aberrant repair. But this reaction will be different in the different age. In the younger age, the normal tissue regeneration will be there. But in the aged people, there will be a not proper repair will happen. Ultimately, as you increase the age, there will be different complication may happen. Okay. So these are the known and unknown form of interstitial lung disease. Unknown, this is known as a IPF, interstitial. Idiopathic, where there will not be any cause. IPF, NSIP, and other. And no unknown granulomatous or sarcoidosis, maybe vasculitis, eosinophilic. But ultimately, we don't know the pathology. Here we know, okay, these are the causes, like connective tissue disease, polymyositis, many muscles are inflamed, scleroderma, these are the connective tissues. Occupation related asbestosis, beryllium disease, or farmer's lung, and many more. Environmental, hypersensitivity pneumonitis like mold in birds, or some drugs like amiodarone. Amiodarone is a diuretic drugs. This diuretic drug may go for the fibrosis of the lung. And nitrofurantoin is again which is related to anti-malarial drug that may cause this fibrosis. So these are the just classification. So ultimately, what we have seen the same thing here. The unknown causes they have given. So if you write this way, this will be better. If you write this way, it looks good in comparison to this one. So now what are the symptoms? Again, patient will be having a progressive breathlessness with the exercise. Students, you need to rejoin, okay?